Next, I call upon Dr. Neethu Pradeep. She will be giving a talk on anti-VEGF treatment regimens in retinal vascular occlusion. Dr. Neethu works as a medical retina consultant in Amardeep Eye Care Hospital, Kollam, Trivandrum.
Good afternoon, everyone. I'll be dealing with anti-VEGF regimens in vascular occlusions. So, RVOs are the second most common of retinal vascular pathology. Untreated RVOs can lead to permanent visual loss, and there is a high systemic implication, that is, there is increased incidence of stroke, and in patients below 69 years, there is high mortality. So these are the classification of RVOs, which you know, CRVO, BRVO, and hemi-CRVO. And the pathophysiology. The basic pathophysiology is the Virchow's triad, which results in hypoxia and resulting in VEGF release. So pathogenesis of macular edema. So whenever there is a vein occlusion, there is an increase in hydrostatic pressure leading to partial ischemia. This partial ischemia results in cytokine productions like VEGF and mechanical vascular leakage. Eventually, the partial ischemia will convert to complete ischemia and there is florid macular edema. So the risk factors include systemic conditions like diabetes, hypertension, hypercoagulable state like protein C, protein S deficiency, and abnormal blood flow as in pregnancy and vasculitis. The regimens they have discussed, but I want to highlight one point, that is in PRN regimens, there is high visit burden, but the main thing is more disease escape and under treatment. While we are considering the treat and extend regimen, even though the patients require more injection, the disease escape is less and the visits are also less. These are the major CRVO trials and these are the major BRVO trials I'll be dealing with. First is the Cruise and Bravo trial. In Cruise and Bravo trial, what we do is, Cruise trial is for CRVO and Bravo is for BRVO. We give ranibizumab 0.3 milligram, 0.5 milligram and sham treatment in the first 6 months. So based on this study, its 0.5 milligram works better in BCVA as well as in CFT reduction. Bravo also have a similar result. So based on Bravo and Cruise study, the final conclusion is that early aggressive treatment followed by PRN regimen results in good visual and anatomical gain at 12 months, and delayed treatment compromises the visual acuity, as you can see in the sham group. Next is the Horizon trial. This is a 1-year extension of the Cruise and Bravo trial. In Horizon, we are following up the patients every 3 months. So the final result is there is no new adverse events, and vision in BRVO patient remains stable. However, in CRVO, the patients had a decline in visual acuity. So we finally concluded that CRVO patients requires more frequent follow-up and the treatment should be individualized. Next is a RETINE study. That is a 2-year continuation of the Horizon study. In RETINE study, we are following patients monthly in first year and 3 monthly in the second year. So based on RETINE trial, what we conclude is that BRVO patients, when they are at 4 years, the long-term visual outcome is excellent and 50% requires occasional injections. While in CRVO, the long-term outcome is always guarded and more than 50% require frequent injection and they have a guarded prognosis. This is the Bravo RETINE trial and the CRVO RETINE trial. Next is the Brighter study where we compare ranibizumab with ranibizumab alone, ranibizumab with laser and laser alone. So based on Brighter study results, ranibizumab with or without laser had a superior visual acuity and greater CFT reduction, and addition of laser did not reduce the number of injections, and macular ischemia did not play much role in final BCVA. Next is the Crystal study, that is a 3 monthly injection followed by PRN, and the patient maintained sustained visual acuity. Here also they concluded that there is not much role for macular ischemia, and early we start the treatment, better the outcome. Next is the Galileo and Copernicus study, which is about the aflibercept. That is, the study concluded that aflibercept is effective in controlling the macular edema in RVO, and early intervention better the outcome. Next is the Vibrant study, which compares aflibercept with great laser, and it concluded that significantly more eyes gained more than or equal to 15 ETDRS with aflibercept over great laser. Next is the brolucizumab Kite trial, which compared the efficacy of brolucizumab as well as aflibercept, and brolucizumab is found non-inferior to aflibercept. The other trials are the Kingfisher and the Merlin trial. Next is the magical drug that is a faricimab, which acts on angiopoietin 2 and VEGF. The trials are Bellatin trial in BRVO and the Camino trial in CRVO. In this, faricimab is compared with aflibercept, and the final endpoint is we can extend dosing beyond 12 weeks in faricimab patient, and there is sustained fluid control, and the visual acuity is compared as that of the aflibercept. The continuation of Bellatin and Camino trial, that the RONEX trial is still going on and the results are yet to be published. Next is the KSOS trial, that is the ILIA HT trial or aflibercept 8 mg, wherever we compare ILIA 2 milligram with 8 milligram, and at 36 weeks it was concluded that 8 milligram is non-inferior to 2 milligram dosing, and more than 90% maintained 8 weekly dose. Next, going to the real clinical situations, what are the prognostic factors? First is the baseline visual acuity. So suppose if you are seeing your patient, if the visual acuity is more than 6/12, 80% will have a good prognosis. And if you have a BCVA less than 6/60, 80% will have poor prognosis. Next is the baseline CFT. If the initial baseline CFT is high, the prognosis is poor. And if you are seeing CFTs above 500, eventually they will go for steroids. Next is the clinical examination. That is, if we are seeing collaterals or if we are seeing spontaneous reduction in macular edema, the patient is doing fairly well. Next is the OCT biomarkers. SMD responds well. IRF, drill and roll responds poor. Next is the FFA. Suppose you are doing an FFA and there is large CNP areas, it requires higher anti-VEGF dose. How will you classify responder versus non-responder? That is, if a patient is partial responder, if there is at least 10% reduction, and non-responder if it is less than 1% reduction. Non-ischemic CRVO, what we do is, if there is macular edema, we'll inject every 3 months and then we'll follow up. If the patient is going well, we can continue the treatment, and if the patient is still going bad, we can wait for 3 more months, or we can have a switch based on the OCT biomarkers. In managing ischemic CRVO, that is 30% of non-ischemic will convert to ischemic in 3 years. Every visit, we have to see whether there is new vessel, and if there is new vessels, we have to start PRP. PRP is like aggressive PRP, and in contrary to our conventional PRP, we need to do a concentric PRP because of this new vessels, the pupil may not be dilating, and each and every visit we can see the pupil is dilating. And if the IOP is not getting control, if it is going to NVG, we need to add anti-VEGF, and we have to have a good connection with the glaucoma consultant. The follow-up, it is monthly follow-up, then quarterly, and finally the patient has to follow up till 4 years. BRVO, the macular edema management is almost the same. And when we are seeing a patient with NV, we need to do a sectoral PRP. NV with pre-retinal hemorrhage or vitreous hemorrhage, we do sectoral and wait. And if no response, we can add anti-VEGF. And if there is TRD or full-fledged BH, we can plan via surgery under anti-VEGF cover. Then the follow-up schedule in BRVO is much more less stringent. That is, the patient can be followed up monthly, and then based on visual acuity, or we can follow the patient on PRN regimen. When is the steroid switch? These are the factors. This is the future direction, is expanding options beyond ranibizumab that we all are doing. Then the long-acting faricimab durability is beyond 12 weeks, gene therapy and personalized AI-based OCT. So take-home message is, initiate early treatment, switch early, treat and extend works for CRVO, and macular ischemia does not have any much role. Long-term follow-up is needed, and newer agents has reduced the treatment burden to the patient.